I'm very happy to introduce our next speaker of the day, Dr. Kumanan Shanmugam, Consultant General Physician and Diabetologist at Chennai Urology and Robotics Institute Hospital. He has completed his MBBS from St. John's Medical College, Bangalore, following which he completed his MD in Internal Medicine in the UK. He also has done his postgraduate training in General Practice and Family Medicine in Southeast Scotland. He is a well-known doctor based in Chennai who specializes in internal medicine and has been practicing for over 23 years. His field of expertise and interest is in general, family medicine and geriatrics. He specializes in diabetes management, allergy treatment, irritable bowel syndrome and insulin-free treatment. Beyond affiliation with many hospitals, professionally, he has been an active member of Royal College of Physicians, United Kingdom. He is currently practicing at Chennai Urology and Robotics Institute Hospital and at Chennai One Health Center. We are very happy to welcome Dr. Kumanan Shanmugam. Over to you, sir.
Thank you, ma'am. Thank you for that excellent introduction. And also I thank Dr. Anand for the excellent talk on urology and robotics. Can everyone hear me, please?
Yes, sir. Yes, sir. We are able to hear you.
Okay. And let me share my screen. And first of all, I would like to thank the Urology Institute and the Indian Medical Association for giving me this opportunity to do this talk on COVID-19 and diabetes, the present challenges and recommendations. I take this opportunity to give my condolences to all those medical staff, doctors who have lost their life in fighting this coronavirus. And I also thank the frontline healthcare workers and the volunteers who are helping us to fight this coronavirus. Coronavirus, the COVID-19, is one of the greatest pandemic that I think mankind has faced in the recent past. It's such enormity, and what I see is diabetes is also a slow pandemic. So there is interaction of two pandemics, which is giving rise to such an amount of health emergency across the world. So in preparing this talk, I've gathered information from my personal experience and practice, and also I've looked at some peer-reviewed journals, especially Stephen R. Bronstein for practical recommendations, and for a Indian National Strategic Framework from Dr. Mohan Vishwanath, and then an article on what as clinicians, what we need to do from Eleni Papadowski. And I would like to disclose that I don't have any conflict of interest. So this pandemic is really a race. At the human level, at the body level, there is a race against to fight and contain the infection. That's the reason I put it as the race. So the moment the body enters, the virus enters our respiratory system, it latches onto the ACE2 inhibitors and opens up the cell through the spike protein, and immediately there is a proliferation of the virus within our lung tissues. If we are able to contain this infection, the virus replication is stopped. But if it doesn't and patient develops symptoms, then the growth is exponential. So there is a race there between our immune system and the virus. At another level, we are running to create a vaccine or find a cure for this virus. At a third level, our economy is going down the drains. We need to do something to scaffold it and bring it up so that we can fight this virus. At another level, we have lost our individual freedom, and that is more important because of the lockdown. We can't go out, we can't do our normal activities. So at various levels, we are having a race with this virus. So a little bit about this virus. way back in 1930, some people who were having upper respiratory tract infections, when they collected the specimens, they found few viruses which they could not actually culture. So for a long time, this was the difficulty. Then they developed organ culture, and they could, in 1964, they first cultured these organisms, these viruses, and when the electron microscope came into use, this was the first picture taken up of the coronavirus at that time. So there was a ring around the virus, and so they named it corona, which is crown. So the picture we are seeing in the middle is the coronavirus electron microscope study done in India, and this is the genome, complete genome of the coronavirus, containing about 30,000 nucleotides. The reason why this, within few weeks that we had the virus, we found out the complete genome, and this has helped us to find out how this virus, it's a novel virus and it's new to our immune system. So if we had any previous similar infections and our body had immunity, some of us are able to cope. Otherwise, it's causing a havoc to our immune system. So completely deciphering the genome has helped us forward to bring up possible treatment and vaccination. So Dr. Li Wenliang is an ophthalmologist who was working in the outpatient department in Wuhan, and he noted that there was acute respiratory syndrome, like the disease pneumonia happening in people related to the wet market in Wuhan. This was way back in second week of December 2019. Then as he was seeing more patients, he was seeing that the humans could be a vector, like that there could be a transmission between people to people. He warned his colleagues to wear protective, do protection, wear masks to protect them against the virus. So by 30th of Jan, the WHO declared it as a public health emergency, and by 11th March it became a world pandemic, and now we have 20 million of people affected, and more than 7 lakh people already have died. So in comparing this virus, I would compare it, give an analogy with an USB stick, because as you know, viruses need a living cell to divide. So, and they don't move out on themselves. So they need a vector. So humans, they act like vectors, like when we sneeze, when our body fluids spreads in the air, like coughing, then each virus acts like an USB stick, and the ports are our mouth and ears. They get connected and they start multiplying within our body. So the symptomatology, following an incubation period of 2 to 14 days, majority of people develop simple upper respiratory tract infections like cough, fever, shortness of breath, and sometimes we can have GI tract infection as well. So fever is most consistent, about 98%, followed by dry cough, fatigue, sputum production, and the shortness of breath. Some people may have short muscle pain, sore throat, headaches, chills, and GI symptoms as well. Then following that, about 10 to 11 days, there is a late phase where they start feeling breathlessness and fall in oxygen saturation. The reason why I have marked shortness of breath, that symptom, the shortness of breath or any breathing difficulty, is a sign that the lungs are getting overwhelmed. What we see is that even prior to that, people's saturation start falling, but they don't have the symptoms, corresponding symptoms. This we call as happy hypoxia. So that is why we are saying we need to check the people's saturation as part of initial examination, so that we can identify the fall in saturation very early and identify those people whose symptoms is going to worsen. So when we advise our patients, we can encourage, empower them to get these small pulse oximeters which they can use at home, so that they can identify fall in saturation very early. Coming to people with diabetes, we know that people with diabetes do not show acute symptoms in the beginning. So like a normal person, they may not have, their fever may not be high, and they may not show up acute inflammatory symptoms in the beginning, but their deterioration comes very fast. So we need to, even if there is a mild symptom, we need to make sure, is it a possibility of coronavirus? Other thing is, somebody whose blood sugar has been very under good control and suddenly their blood sugar is shooting up and down, then we need to wonder whether it could be an infection. And because this is corona time, we need to know whether it could be corona infection. And especially in type 1 diabetics, if there is a deterioration of glycemic control, then there's a possibility that they can go into diabetic ketoacidosis fast, and we need to have ways of bringing them into hospital and treating them. So a little bit about the coronavirus and how it interacts with our body. Surprisingly, the two major endocrine receptors we have in our body, the ACE2 receptors and possibly the DPP4 receptors, which causes the incretin effect. These two are involved in this virus. When we had coronavirus 1, we knew that it affected the ACE receptor. So the coronavirus 2 also affect the ACE receptors. And when we had the MERS virus, the Mediterranean Respiratory Distress Syndrome virus, it selectively targeted the DPP4 cells. So these coronaviruses are somehow, they are very, very close to human endocrine system, so that their complications are very severe. So we'll see a little bit about the cytokine storm, because when coronavirus enters the body, it causes infection of the respiratory epithelium, necrosis, and it leads to pneumonia. And there is impaired neutrophil function, impaired interferon production, gamma production. There is disruption of CD4 cell, 8 and 4 cells function, and there is cytokine storm with the production of interleukins and interleukin 1 and interleukin 6, which causes quite a bit of damage to the lungs. So if we remove the SARS-CoV-2 and put diabetes, we find that diabetes also causes similar problems and causes a low-lying inflammation, which makes them prone for all these pathophysiology to happen very fast. And there is also increased expression of ACE2 in diabetics. And there is a molecule for furin called furin molecule, which is inside the cell and which helps actually endocytosis process within our cells. And the coronavirus seems to hijack this furin molecule in order to form vesicles and start the process of endocytosis. So in this way, the coronavirus seems to have adapted to the human cell so that it can easily invade and proliferate. The angiotensin converting enzyme 2 is seen in organs like lung, liver, kidneys, heart, and even in pancreas. So there is a hypothesis that these viruses can block these receptors and cause underfunction of pancreatic cells and lead to hyperglycemia. What we see is in people who, elderly people especially, who get coronavirus, their blood sugar shoots up even in spite of not having diabetes. One of the reasons is the cytokine storm, stress-induced hyperglycemia. The other is the possibility that the pancreas is getting affected, their insulin secretion comes down. That makes them susceptible for secondary bacterial infection and complicating the whole clinical picture. Also, ACE2 enzyme as such helps to convert angiotensin 2 to angiotensin 1,7. The angiotensin 1,7 is actually anti-proliferatory. Because its levels is low, the angiotensin has sufficient quantity to affect the angiotensin receptors, causing vasoconstriction and a pro-proliferative state with accumulation of insulin, inflammatory fluid in the lungs, and leading to complications. So when we look at the risk factors, the study you see on the left is the actually data that we got from reported from United Kingdom of patients admitted in the hospital with complications. On the right side, we see what are the usual risk factors. So what we see is that age is one of the major factor with the hazard ratio. Any hazard ratio more than 1 is significant. So the hazard ratio of nearly 13.59. Then diabetes, chronic cardiac diseases, chronic renal disease, obesity, and pulmonary disease. So if you see the people at risk as reported by Mohan et al., the age 65 and older, all ages with underlying medical conditions, particularly if not well controlled, diabetes, COPD, serious lung problems, CKD, liver disease, and those who are compromised. Also, I'll later talk to you about a study relating to obesity. Severe obesity is a major risk factor. Another thing is living in a nursing home or long-term care facility. So these are some of the data coming from India. Confirmed cases have gone about 2 million people, and most of them have recovered. And we have a death of mortality of about 42,000 people. So if we take by statewide, Maharashtra and Bombay accounts for majority of deaths in India, and in Tamil Nadu, those who are above 60 have major about 70% of the deaths are in people with either diabetes or hypertension. So, so what is the interaction between the personal health and society? So this is where how the society is tuned to face a pandemic comes into force, and the interaction of the individual and the society creates a platform for how the pandemic is going to proceed. So personally, we have our lifestyle. What is our general lifestyle? Our diet. Is that leading to a chronic inflammation state? And how the aging population is, and genome. For example, nearly 40% of people who are getting the infection with coronavirus, if we do the antibody test in the initial period where they don't have any symptoms, and in spite of having the virus, they don't have antibodies. But there is some genomic ability. Say there's a lot of theories like previous vaccinations with BCG and all those things. But we know that the genome, some genomes are primed and they're able to cope with the infection, whereas others succumb to it. So the genome plays a very important role. And in the society, as the infrastructure is the health-related infrastructure, how the government is processed to face the pandemic, their policy, what is important for them. Because we have so many class differences, so many economic variations. We have the richest people in the world and the poorest people in the world. What is the priority for the government? How is the culture and customs influencing? For example, in Italy, when there was lockdown, people got together alone and families and parties. That was their culture, like being on holiday is going to the beach or going to the party. And we cannot call up for strict social distancing like how we do it here. So the cases went up. The mortality rate went up. So there is an interaction between the society and the individual. So the reason why I put up this slide is for future people who are going to be at the level of controlling poverty or forming health-related infrastructure, we should keep this in mind to cope with any pandemics in the future. So what I see is diabetic itself is a slow pandemic. We already have 1 million people dying every year due to diabetes or diabetes-related problem. It's because we are not identifying it. We need a corona to come and show, okay, this is what is the death rate in diabetes. If you take 75 million people are affected with diabetes, and every year 1 million people are dying. Is this not a pandemic? We are having a pandemic, but we are not recognized. If you say 12% of the world population in lower and middle socioeconomic countries, 12% of the population is with diabetes. So the death rate in diabetes is most common in vulnerable people, elderly people, 60 to 69 and 70 to 59. So the WHO, is, the World Heart Association is saying by 2035 there will be 109 million, which is 77 million at the moment. So what are the precautions that we need to take? Apart from the general precautions or the universal precautions that we are advising, like hand washing, social distancing, wearing a mask, avoiding gathering, the special precautions for people with diabetes. And that is to a person with diabetes, anytime any emergency can happen. They can be high sugar, low sugar. So they need to have relevant contact details with them. Pay extra attention to one's glucose control. Later I'll show you a study about how often people do studies. But what we need to empower people to do blood glucose monitoring very often, especially when the time that they can't access a healthcare professional. And in case of any flu-like symptoms, like say mild temperature, cough, difficulty in breathing, it's important for them to immediately call up and consult with their doctor. Most of it, what happens, there is denial. They don't deny, it's a common cold, I'm having a slight fever, and they try to brush it under the carpet. They don't want to talk about it. There is a bit of social stigma attached to having even testing for corona. So we need to encourage them that if there is a possibility, it could be corona. So there should be sufficient regular intake of water, maintain their hydration, adequate diabetes medicines, and make sure they have enough food. Make sure they'll be able to act if the glucose drops suddenly, like we discussed sick rule day, what happens if they become sick, how much, so we have prepared a plan with the patient. So ensure good nutrition by eating varied and balanced diet, recommend food that are those with low glycemic index, avoid excessive consumption of fried foods, limit consumption of food high in sugar and carbohydrates and fats. So already we know having diabetes makes people prone for infection, especially highest rates in joint infection, sepsis, and cellulitis. So hyperglycemia itself causes the dysfunction of the immune system. HbA1c 9% has increased risk for 60% increased risk for hospitalization. So when we had coronavirus 1 in 2002, we had a lesson. We knew this virus is going to affect the ACE2 receptors, and those people at that time had hyperglycemia, and those individuals who had hyperglycemia had mortality rate was high. So in MERS in 2012, the odds ratio that is was 7.2. 1 is significant, so they're 7.2 to 15.7. For nearly 35 to 40% of those with diabetes died because of the MERS2. And even in influenza, people with diabetes, there was triple risk with hospitalization, and the chance of them getting admitted in the intensive care was 4 times. So what's the effect of diabetes in COVID-19? 20 to 50% of severe outcome happening with including ICU admission and deaths are related to diabetes, and its comorbidities like obesity and upper age group is contributing to this factor. There is poor viral clearance, there is impaired neutrophil function, there is increased ACE2 expression, like I said before, and then there is increased incretin seen in diabetes, which are the membrane bound proteins involved in entry of coronavirus to the cell. There is impaired T cell function and in fact impaired increased interleukin 6, which is damaging to the cells. What we see is COVID-19 attacking the ACE2 receptors in the pancreatic cells may be causing hyperglycemia, even in people without previous history of diabetes. And these are some of the studies that I've gone through. What I would like to see is the retrospective study in UK, which had about the heart hazard ratio of 1.5, and that went up to more than 2.36 in people with higher HbA1c. And also in China, which is a large study, diabetes and patients and diabetes diabetes with corona had a 7.3% more mortality rate or risk compared to people without diabetes. So this is an interesting study, Coronado study done in France. This was mainly in diabetic patients with high uncontrolled blood sugar with HbA1c more than 65 or 8.1%. What they found is one consistent factor which was causing the prognosis becoming severe and the death rate at the end of 7 days higher is obesity. So if we have a patient who is a diabetic, who has uncontrolled blood sugar and who is obese, we need to just make sure that this person is monitored and his blood sugar levels are controlled. And there's another study in China which showed that good blood sugar control, the survival rate is 98%, whereas HbA1c below 10, there is a chance of 11% risk of death. So what is it that is between corona and diabetes? So studies have shown that diabetics are at the same level of risk of contracting the infection as a non-diabetic, as long as they follow the universal precautions. But diabetes by itself, we need to know that it's an uncontrolled proliferative state with impaired immunity. There is upregulation of waste and furin protein, leading to proliferation of the coronavirus with increased viral loading following the infection. The hyperglycemia and related fluid depletion leads to vasoconstriction and circulatory compromise, leading to a hyperosmolar state and propensity to pulmonary embolism, stroke, renal failure, and bacterial pneumonia. So coronavirus leads to cytokine storm with high levels of tissue necrosis factor alpha and interleukin 1 and interleukin 6, leading to lung damage. This also leads to hyperglycemia, that is impaired T cell function and impaired interferon gamma production. The elevated inflammatory fluids in the lungs leads to alveolar edema and failure of oxygenation. There is leukopenia and thrombocytopenia and high levels of ferritin, leading to thromboembolism, ARDS, respiratory failure, and assisted ventilation. So if you see diabetes complications and comorbidity, you see association of obesity, inflammation, coagulation, thrombophilic state, hyperglycemia, old age, hypertension, and renal disease. And if you take corona, the SARS-2 virus causes beta cell damage, causing hyperglycemia, and causes cytokine storm, worsening of worsening of metabolic disease, or also causing new onset diabetes. So it's a double pandemic that we are seeing. So treatment-wise, there is an international consensus, and this is a national. The one on the left is the national strategic framework advised by Mohan et al. Both are same almost. We need to keep the fasting plasma glucose less than 120, and postprandial less than 180, HbA1c less than 7%. The treatment recommendations are DPP-4 inhibitors are generally well tolerated and can be continued. We need to think about metformin, because in a dehydrated state it can cause lactic acidosis and also cause renal compromise. The SGLT inhibitors have been recently coming into use largely by diabetologists and also cardiologists, and they have risk of dehydration and diabetic ketoacidosis. So patients should stop taking them if they are admitted to hospital. GLP receptors once again can cause dehydration. If they are insulin therapy, they should continue it. The main thing is regular monitoring of blood glucose. They need more frequent close monitoring and adjustment of insulin based on blood glucose values. And also they should check blood glucose and urinary ketones if they are type 1 diabetic for hyperglycemia and ketoacidosis. The international consensus, they talk about the same thing, but they talk about one factor called time in range, which is how much of time in a day that the patient's blood sugar controls are within normal range between 3.9 to 10. We have very few patients on type 2 diabetics with on continuous glucose monitoring, whereas type 1 diabetics are. and we can do flash glucose monitoring and see if their values are within this range, more than 70%. This is coming into more use the time in range, as we note that the HbA1c can be inconsistent in elderly people when they have some due to senescence of the RBCs in elderly people, their HbA1c values can be low. But using the TIR, which can, where they're developing a protocol, we can do flash glucose monitoring or CGM, so that this is kept under range to prevent any complications of diabetes. In patients who are needing hospitalized, we need to look for any comorbidity. If there's 1 or 2 comorbidities, the risk is high. So we need to have low threshold to bring them to ICU. High CRP, elevated EGFR, HbA1c more than 7.5%, hyperglycemia, abnormal blood gas analysis, elevated troponin, and any involvement of cardiac or possibility of elevated D-dimer, they need to be going to ICU. We need to stop all oral hypoglycemics and switch to insulin, and do continuous monitoring of their glucose. If they are already on ACE inhibitors or ARBs, we have to continue them, but we have to check whether their cardiac functions are within normal range. So glycemic control, we need to keep the blood sugar within 70 to 180. If there is more than 180, the mortality rate is high, and patients well-controlled diabetes had lower inflammatory markers. A retrospective study of patients in US showed that people with hyperglycemia had a longer stay, and a subset of people with high blood sugar, even without diabetes, had 7-fold greater of mortality. So glycemic control is important. Asymptomatic infections, we can, asymptomatic infection with home care, symptomatic patients, hospital care, usual therapy, whether plus or minus SGLT2, ICU care, frequent insulin monitoring and dose of insulin or IV insulin. We need to look at the comorbidities and prevent any complications. In prevention, people with diabetes, we know, are a vulnerable group. We have to adapt, we have to create adaptive strategies in health services. We have to build up our capacity for emergency preparedness. So some drugs like DPP4 inhibitors can be used, but they can have an interaction with lopinavir. SGLT2, as I said, there's risk of dehydration, electrolyte imbalance. Same with GLP receptor. Sulfonylureas can risk of hypoglycemia. And they also interact with lopinavir and hydroxychloroquine. Pioglitazone is an anti-inflammatory. Once again, it can cause fluid retention, and it can interact with favipiravir. Insulin is recommended in critically ill patients. Of course, there is risk of hypoglycemia, and we need to check, we need to monitor their hydration and maintain their blood sugar. They can also interact with hydroxychloroquine, because hydroxychloroquine by itself can lower blood sugar. So what are the challenges? There is limited access to healthcare. There is a face-to-face consultation is lacking. There is poor glycemic control, access to medicines, lack of income. People are not able to work. They're they are not able to buy medicines. There is fear of illness, uncertainty. And in our country, there is limited resource of video or online consultation. There is inability to use smartphone technology, so that we cannot real-time interact with the patients. Lack of integrated national registry to connect people with existing services, lack of psychological support, though it is coming up more, because people are, uncertainty causes anxiety, and that makes their blood sugar go up and down, and that contributes to morbidity and mortality. Lack of robust evidence-based practice for native and Ayurvedic medicines. Government is supporting some medical Ayurvedic, though they may be effective. There is no any studies showing them, and there is also a lot of evidence-based medicine to be practiced in this route. So how to help manage diabetes? I'll quickly run through this. We need to replace active follow-up. Patients are not able to come, but we have a record of patients who are diabetic or obese or blood sugars are fluctuating. We call them and say, we check on them how their blood sugars are. We find some ways for them to do blood sugars and report back to us, or establish vibrant centers locally in the hospitals or mosques, active outpatients and clinic. We can use corona surveillance team to visit home and focus on elderly people with comorbidities and diabetes, recommend self-monitoring of blood glucose by providing glucose monitors, utilize text messages, provide guidance for physicians how to manage clinically patients, allocate individual telephone numbers in the hospital for people so the diabetics in emergency can call, send an educational video by smartphone. Understanding and emotional responses to pandemic is very important. Establish standards of care, bringing back some order to routine in the times of uncertainty, managing stress, leisure, parenting, and relationship. So in terms of about standards of guidelines, there is a few things like where we need to have face-to-face consultation. If there's a new type 1 diabetes, we need to see the patient. Or if HbA1c is more than 10% ketone detected, we need to teach them to do blood glucose. They may need IV fluid. We may need to bring them into the hospital. And we need, these services have to continue. We may have forfeit some consultations regarding eye screening or food services, depending on what the patient's needs are. Pregnancy services need to continue. All consultations can be done through telecare should be followed. Face-to-face only in regards to urgent consultations. Patients can empowered to do self-monitoring, so they can check their blood sugars at home and report to the doctor. What you see in the lower side is a chart showing diabetic patients who were called up during COVID time to see if they are checking their blood sugars regularly. It was noted that only 25 to 30% were actually doing. If we see a new patient, we need to encourage them to do blood sugars. And we need to teach them the importance of home blood sugar monitoring. These are the vaccine in place. There are nearly about 40 to 50 vaccine on the anvil. Covaxin is phase 2 trial, and we have another vaccine, Zycov-D, in phase 2 and phase 1 and phase 2 trial based on measles virus. And hopefully before the end of this year, we should have a vaccine to help control the infection. So as a take-home message, I would like to run a few problems. Coronavirus is a diabetogenic virus with propensity to cause hyperglycemia. So we need to actually screen for diabetes in our patients. Uncontrolled diabetes with obesity poses about 50% risk of adverse outcome. Diabetes is a slow, deadly pandemic that is prevalent in our society. We need to educate our patients for self-care. In future consultations, we need to talk about home blood sugar monitoring and record keeping. Integrating corona surveillance with blood sugar monitoring of vulnerable patients is a possible route. We need to talk to the local public health care team and involve them. Encouraging blood sugar monitoring, sharing with us so that we can promptly intervene. Promote diet and exercise along with the universal corona precautions like social distancing, hand washing, and mask. Remember the values: 70 to 120 fasting and 70 to 180 random. If values exceed this, we need to take action. Encourage home oxygen monitoring with pulse oximetry, and any value less than 94 to 100, take action. Encourage hydration and physical activity. Focus on psychological well-being with web-based psychological intervention, which is becoming available. Elderly who stay alone need help to build up social support with family, friends, and local groups. So I talked about so much of corona, and I would like to finish in a positive note. With the advent of corona, with the lockdown, our environment has improved. What you see is the smog in Delhi and Bombay, and what you see is the clarity shows how much it has helped the environment. And what you see is the Ganges flowing pure after millennia. And that's the end of my talk. And what you see on the right side is a picture of corona drawn by my nephew. It looks very perplexed, and I think it's us who are perplexed because of the coronavirus. And if there is any questions, please come forward. Thank you.
Thank you, sir. It was a very, very wonderful presentation in detail. We have one question from Dr. Mohana Das. He's asking about the role of BCG and MMR in prevention of COVID-19, sir.
Yeah, what happens is because we had this in the national program, BCG has given a baseline of immunity against many infections. So that's, as I talked to you about in the genome the ability to combat, prevent infection. So these infections baseline is giving a protection to people. That's why people abroad are now starting experimenting giving BCG vaccine in the time of corona to see if it is causing any protection. Okay.